Move over to these fine tipped ultrasonic tips here, and I'm just being very, very, very gentle around this area. Again, these have got a very, very strong risk of causing a false orifice. I'm going to switch to a blue filter in this case, and I don't often use a blue filter because a lot of the times in these cases, you see these highly sclerosed teeth, the canal spaces sometimes will be vital, and then I can still see that kind of orifice in the buccal aspect of this orifice that I've created, and now it catches it really nice. So super, super, super nice feeling there. So we've got the mesiobuccal orifice, now we've got the mesiolingual. So hello, welcome to today's Friday's clinical case. And, you know, this one's a really, really tough one. Probably the most difficult canal that I have actually managed to reach to the end of. And spoiler alert today, this tooth was found to be non-restorable after all of our hard work. And today's case really is to talk about the steps and the journey we've taken to recognise this tooth is not savable. I've had quite a few of the viewers of this channel asking me about talking about failures. So, you know, despite the fact that the tooth wasn't savable, I told the patient that, you know, we get consent off the patient to use the videos. And I said, you know, despite the tooth isn't savable, I think this would be a really good learning experience. So before we get into the case, what I would say is about 50% of the people who watch these videos are non-subscribers. So what I would say is before we start, if you could do a really, really simple and easy and free thing, and that's just to hit the subscribe button. If you hit the subscribe button, I promise that each week every video is going to get better and better. If you could hit the notification bell as well, you'll get notifications of when videos are uploaded. And if you want to take the support for this channel even further, we've got a membership program. The membership program gives you early access to content. So if you love these videos, you can get early access to these videos up to 3 weeks in advance. And also it has exclusive content. So we've got a fantastic endodontic access video. It's about an hour long. It's got lots of videos. It explains how to access teeth before you start a root canal. And that's only available to members. So let's get into the case. This is a case of a lower 6, okay? And when we look at the x-ray here, we can see that there's no obvious canal space in this tooth. And straight away, this is a kind of a red flag for a clinician. When you're kind of looking at x-ray and you're kind of working out exactly, you know, if the tooth is savable, or you're trying to sort of work out what sort of problems are going to be encountered when you do a root canal. And of course, if you sort of look at problems in advance, you can then consent the patient a little bit better. And we can see here that this tooth has got no real obvious canal space. So this could mean that the tooth is highly sclerosed inside as the canal spaces are closed up. Or a lot of the times what you'll notice is the tooth looks really, really closed up. On the x-ray, you get inside and the canals are really, really nice and wide. This is something I'm going to speak to the patient before we start anything. But in this case, the canals weren't wide. And another issue is the restorability. So what we're going to do now is we're going to move over to the tooth here, and I'm going to place a rubber dam. And in this case, I'm going to do a multi-tooth isolation, and I'm going to be using a wingless clamp in this case, because what I'm going to do is I'm going to place the clamp on first, and then I'm going to stretch the rubber dam over the multiple teeth. And I think when I do multiple teeth isolation, usually if you see my normal videos, I like to place the clamp onto the rubber dam. And you can see here, you need a little bit of help from the nurse. She uses her fingers to stretch the dam over the multiple teeth, and then I just kind of floss the contacts. And then I'm just going to place a wedget on the further forward tooth, the most anterior tooth, and then I'm trying to invert the dam over the tooth in question. This is the lower right 6. And when I try and invert the dam, what I'm trying to do is trying to keep the dam around the rest of the tooth, the lower 6, but in this case it's not the case. So I'm just now using a couple of wedges to keep the rubber dam down away from the tooth itself, and this kind of works to a certain degree. Once we've kind of isolated this lower right 6, and then I'm ready to remove all of the decay, and I'm just using a fast hand piece here. So this tooth has got a combination of a temporary filling, it's got decay, and it's also got a permanent filling in there. So I'm just going to remove all that. And what you've got to do is you've got to remove all of the filling material and the decay to see if the tooth is savable, because what you don't want to do is you don't want to complete a root canal and find out the tooth isn't savable. So I've noticed at the back, the distal aspect there's a bit of decay, and but the rubber dam is fitting over this decay, and when I try and sort of invert the tooth with a floss piece, it doesn't work. I try and invert it with a flat plastic here, and again it doesn't work. If I were just to drill the decay out here with the dam in place, it would split the dam, it would open the dam up to the rest of the mouth, and then it wouldn't work very well. So actually in this case I'm going to take another wedge. These are Paladent wedges, by the way, and they're kind of V-shaped, so it fits in that sort of dental papilla and then pushes the rubber dam out of the way. And this kind of protects the rubber dam away from your instruments. So when you're removing the decay, you're not going to nip the dam and cut it and see that it splits. So we've got a nice little bit of isolation there. And I do try to do as much isolation as I possibly can. Sometimes, have you noticed with some of my other videos, I don't often do complete isolation, but in this case, I was happy to do this. And the patient also found it difficult to keep a mouth open. So as well as keeping everything nice and clean here, you can see the decay's all removed. It just pushes sort of the tongue and the cheek out of the way, and it just creates this kind of nice working field. I'm then going to place a matrix band onto this tooth. The problem with a matrix band, of course, is it doesn't give a great contact. But in this case, we know the tooth is going to receive a crown at some point. So the most important thing here is not to create a good contact point between the two teeth. It is to just create a nice, solid tooth, so we can place a rubber dam over it. It's not going to leak, and then we can, use our arrogance with impunity, and it's not going to get into the mouth and things. So we're going to etch and bond here. I'm going to place flow around the edges, so the flow's just going to get into all the little nooks and crannies of this teeth, and I'm going to light cure that. And then once the flow's on, I'm going to use a heated composite. So I've got like a heated composite thing here. I don't know if I can see that on the video. And the great thing about heated composite, of course, is that it just gets it's nice to manipulate, and again it gets nice into all the little nooks and crannies and things. And what you'll notice here is that as I'm placing this composite, it kind of just sort of blocks the canal space a little bit, but I'm okay with that because I kind of know where the canal orifices are. The most important thing here is we just get a nice filling around this tooth, and of course it looks a little bit rough on the occlusal surface, so I'm going to get a fast hand piece and give it a bit of a tidy up. But overall, when we look at this tooth, it's looking a hell of a lot better. But as you can see, the base of the cavity there is blocked. So I'm just going to use a fast hand piece just to remove the excess composite that I placed. And then when we look into the access cavity here, we can see that there are no canal orifices. And this isn't because I blocked it with composite, it's because these teeth are really, really highly sclerosed. But what I want you to notice is that one of our Krasner and Rankow rules about the floor of the pulp chamber versus the walls, and the floor of the pulp chamber is much darker than the wall. So we can kind of see where the floor is, and we'll notice that with the floor, at the angles, at the edges, that's where you're going to find the canal. So that's really, really important. And then first of all, I'm going to try with a size 10K file. Doesn't work very well. That's in the mesiobuccal, and I'm going to just try in the mesiolingual to see if I can sort of get a catch in an orifice. And again, I'm really, 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 really struggling here. And what I do is I have just a very, very quick clean with an ultrasonic tip, high energy. Got to be careful with this, of course, because you can cause a false orifice, and you might just sort of go yourself down a path where you end up perforating the tooth. But I'm just going to get a size 8 here, and I'm going to try down the mesiolingual again, because I feel like that's probably the canal orifice is most obvious, but this size 8 isn't helping at all. So I'm going to move over to a diamond-tipped ultrasonic endo tip here, and this is a very, very low energy ultrasonic, and this is just sort of refining the cavity floors, because sometimes there's only a little bit of calcification over the orifices. You can use these sorts of ultrasonics, it opens up the canal space, but again, it's helped a little bit, but we can still see the darkness of the floor. So this means we know they're in the same in the kind of area that we need to be. And the distal there, maybe that's an orifice, maybe that's been caused by our ultrasonics, but we're just trying to keep essentially an open mind here. So we're going to try a little bit more refinement with our fast handpiece, with our ultrasonics, having a really, really good clean around, lots of water, and then you can see now that the pulp chamber floor is developing slightly, and I feel like maybe we've got a little bit of a catch in the medialingual. The distal certainly has got a suggestion of an opening, but I've been very, very, very careful with these high energy ultrasonics, because if you put a high energy ultrasonic into dentin, it will cut a hole, and that can cause, like I said before, a false orifice. And then I'm going to move over to these fine tipped ultrasonic tips here. And I'm just being very, very, very gentle around this area. Again, these have got a very, very strong risk of causing a false orifice. But I'm looking at the pulp chamber floor. I can see the darkness. I know in the kind of vicinity where these orifices might lie. So I'm just very, very, very gently just refining and having a little feel around. I'm not pushing these anymore. I'm just removing some of the sort of lighter dentin. So I'm just trying to open up the floor a little bit. And again, back in with our high energy just to give it a bit of a clean out. And then I'm just following the darkness of the floor, like I said before. I feel like maybe the medialingual is probably our best bet. I did get a better catch with the medialingual, and I'm just very, very gently having a little feel around with this diamond tipped, and I'm just very, very carefully using this fine needle tipped ultrasonic. And you can only really use these ultrasonics with very, very high magnification, and obviously you can't use these needle tip burrs on a normal ultrasonic unit that you get on your normal chair, because they're too high energy and it'll break the tip if you were to use it on there. And once the orifices are open, I then use a size 8 in the medialingual, and straight away I feel that kind of the resistance, but I feel like the hand file is actually starting to negotiate down this medialingual. So it's very, very tantalizing. I'm just using a little bit of watch winding here just to try and open up this canal space. And once the orifice is open a little tiny bit more, I'm going to use a size 6 here, and it now negotiates a little bit further, but there's still a little bit of resistance. So I'm really, really concerned about file fatigue in this situation. So I'm always inspecting the end of the file here and just looking for any kind of unwinding of the file, especially with these size 6s, because they're very, very narrow and really, really easy to break. In this case, this is a C+ file. But we're looking at the orifices now, and they're looking a lot better. We've got the darkness there, so I know that I'm kind of in the right vicinity. I'm ready to use my size 6 here in the medial buccal to see if I'm negotiating any further, because usually a lot of the times I like to choose a canal space and then just negotiate down there, but in this case I've just been flitting between the two. The size 6 doesn't negotiate very far down in the medial buccal. So what I'm going to do now is I know that I am in the medialingual, but I'm going to do a little bit more investigation around the mesobuccal orifice, and I'm using these needle-tipped ultrasonic tips here. And what I'm going to be really, really careful here is I don't perforate the tooth. And it's really, really hard for you to orientate yourself in the correct way to make sure that you're going down the center of the root. And in this case, I am being really, 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 really careful. I'm using a bit of high energy ultrasonics. But when I look really, really, really closely with my microscope, I can see that maybe On the buccal aspect of the orifice, not the tooth itself, but inside the orifice, I can see a very, very, very small opening. And again, using high magnification, I'd never see this with my loupes. And what I'm going to do is I'm going to pick up a size 6 hand file, and I'm just going to have a little tiny negotiation. And we are looking at this very, very closely. So to try and negotiate and have a feel around with these hand files is really, really difficult. But what I notice is I have a little feel around with a size 6. I'm trying to feel for that catch, because this might just be, you know, just something that's been caused by the ultrasonic. But as I sort of have a feel around with the size 6, I'm getting no joy at all. But I've got this kind of gut feeling that maybe this is a hole and it's been blocked by some dentin when I've been opening up the tooth. So what I'm going to use is these ultrasonic tips just to kind of have a little feel around in the buccal aspect of this orifice. Again, a little bit of water, and then we get our paper point here just to remove some of the pooled water, just so I can see a little bit better. And then straight away I can see that something is opening. So I'm going to switch to a blue filter in this case, and I don't often use a blue filter because a lot of the times in these cases you see these highly sclerosed teeth, the canal spaces sometimes will be vital. So with these blue filters, what this does is it shows up blood, and if you can see blood, then that's the orifice. But in this case, it didn't work very well. So I'm going to do a bit more refinement with the ultrasonic tips, have a little feel around. Again, just very, very gentle, very, very sort of methodical. And then what I do is I get a size 8 C+ file here, and then I can still see that kind of orifice in the buccal aspect of this orifice that I've created, and now it catches it really nice. So super, super, super nice feeling there. So we've got the mesiobuccal orifice, now we've got the mesiolingual. So it's in there, it looks nice. Can you see how the file is sort of pointing towards the buccal aspect of this canal orifice? So again, always keep an open mind. Don't just be too dogged and get down a canal if you feel like you're going the right way. And then we're just going to kind of open up the mesiobuccal orifice here with our glide path file. Have a good old clean out and make sure we're kind of opening the coronal aspect of this tooth. And once we've opened up the mesiobuccal canal, well, the first thing, the reason why I want to open up this buccal canal is because we're going to go to another canal space here, and I just want to make sure that this mesiobuccal canal orifice is open. So when we get back to it, I'm not sort of fiddling around and looking around. So we are going to go back to the mesiolingual because I knew that I was getting a bit further down with this canal space more than the others, and I'm just having a little watch winding feel here with a size 8. And I notice that in the mesiolingual canal with this size 8 C+ file is that I can get to about 17 millimeters. So that's the furthest point that I've reached. And once you are negotiating down calcified canals, what you don't want to do is you don't want to push these files any further than you need to. You want to do this kind of step back approach. So in this case, I'm going to use the tooth saver method. And what this method is that it's kind of a step back approach where I'm going to get a size 1802 rotary file here, but it's going to be in a reciprocation motion. And this is a patented reciprocation motion by Daniel at Tooth Saver. And the motion on this is 400 degrees forwards and 50 degrees backwards. And you can only do these kind of modified approaches if you've got an endo motor, which you can you can change the settings quite easily. And what we're doing is doing a little bit of a pecking motion here. And what Daniel suggests is that you place the file to as far as it'll go with it off. But in this case, I've noticed that if I have it left on, it works just as well. But I don't think Daniel at Tooth Saver would say that was a good idea, but that's just the way I work it. And then once we've shaped up the 1802 at 16 millimeters, I'm going to get get my size 8 hand file back in, and it does actually go a little bit further. So we've gained 1.5 millimeters, so now 18.5. And then we're going to get our size 1403 tooth saver file using the same reciprocation motion, 0.5 millimeters away from the furthest point reached, which is 18 millimeters. And we're just going to use that patented reciprocation motion, and then we're going to use the 1802 after the 1403. Again, at the same level, we're not going to be pushing it any further. Remember, we're doing this step back approach. We're opening up the canal space, ready for our hand files. And then we're going to get a size 8 hand file again, and we're going to just see if we're going to get any further with this file. And we'll notice that as we sort of negotiate this size 8 further to length, that it is slipping a little bit further. So we hook up the apex locator, and we know that we're very, very close. We're at 20 millimeters on this, and on the apex locator, it shows that we're very, very close to the apex. So it's just the same as before. This time we're using the 1403 at 19. So this is about a millimeter away from the first point reached. And then we're using a size 1802, and then we're going to go back in with the size 8. And when we hook this size 8 up with our apex locator, we can see now that we've reached 0, which is fantastic. So this is a quite a huge achievement. We've gone from completely sclerosed and closed up to a open and patent canal. And in this case, I was very, very happy at this point, because I was thinking, oh well, I'm going to do this with all the 3 canals. However, it wasn't to be. But I'm gonna shape this mesiolingual before we start with the distal and mesobuccal. And what I'm going to use here is a high flex 2004, and I'm not going to be opening up this canal space too much with a higher diameter file, because I'm concerned about ledging. We already know it's quite sclerosed. And also what I'm going to do is I'm going to recapitulate every time. That's really important. Make sure that the canal space is open. And we can see here now that the mesiolingual is nicely shaped. However, we move over to the mesobuccal. I do the same sort of protocol, and it transpires that I can only get to 18 millimeters, which is short of the working length, because when we hook it up to the apex locator, it didn't show 0. And usually if the mesiolingual is 21, then the mesobuccal is going to be around the same situation. So we know that the 18 is, a good couple of millimeters short, which in root canal is a very, very, very long way. 4 millimeters short is a lot of space for bacteria to proliferate. And also we attempt to go down the distal, and in this case we can only get down to 10 millimeters. So I spent a significant amount of time on these 2 canals, but we got to the point where we'd spent 2 hours on the tooth. I felt like these teeth were too closed up. And then, you got to ask yourself, what next? What's the next thing for this patient? Well, first of all, what I'm going to do is I'm just going to close the tooth up. I'm not going to have a conversation with the patient as they're sitting back like this. So we're going to dress the tooth with non-setum calcium hydroxide, PTFE tape, and glass armor cement. And then we give the patients 3 really, really stark options. The first option is just to do nothing. You can always give the patient the option of doing nothing. And a lot of patients go for this option because they're happy to take the risk on, but we need to be absolutely clear with the patient that the tooth is not being shaped and clean adequately enough, and eventually the tooth is going to become painful. But a lot of people get to the point where they're happy as their teeth is, and if it becomes painful, then that's their issue. Another option, of course, is just to take the tooth out. This is probably the option that's in the patient's most best interest in this situation. The problem with that, of course, is the patient's going to have a gap. I do talk about gap options, but to be honest, a lot of these patients are external referrals, so I will just give them kind of nominal options, but I'll say the best thing to do is speak to your normal dentist. And then finally, the most obvious is they can be seen by another clinician. I'm not a specialist in root canal. I have a master's degree, but I'm not on the specialist register. And, if you're a person who likes to do root canal and you do some big cases, but you're not a specialist, I always give the patient the option to say, You know, you could see a very good friend of mine down the road who might be able to attempt it. But what you do say to the patient is that, you know, there's a possibility that this person is you're going to spend money on a consult with this specialist. They're going to spend time and effort on this tooth, and they're going to charge you for the attempt. And don't forget, I have also charged them for this attempt. So despite the fact that I couldn't do the root canal, the patient is still charged for this appointment. And I could say to them, you know, you could spend 2 lots of money, or you know, you can invest a little bit of money and try and save, but it might not work. So overall, you know, I will leave it up in the air about how the patient decides to leave this tooth, because I feel like, you know, it's an irrelevant thing for the appointment, and I wanted to respect the patient's choices in this case. But overall, thanks for watching. It's great to show the cases where they didn't go so well, or we didn't actually save the tooth, just to give you an idea of what to do if it doesn't go all well. And I always think they're probably the most biggest learning points for for clinicians. And again, you know, if you haven't subscribed already, please subscribe. If you want to support the channel, join the membership program. We've got exclusive content, we've got early access to content, and I will see you in the next video next week. Bye bye.